Thank you, Steve. Thank you, Bruce. Thank you all for being here. We'll talk about this idea of the era of personalized IBD management. The title is The Future is Bright. I'll tell you, there are really three different things I'll get at here. One is we're doing personalized medicine in our care, and I'll review how we can do that better with the tools that we have available right now. There's some near-term things that are not quite ready for prime time, but getting close. And then there's some futuristic ideas that are getting closer, and I think really gets us excited about the future. We have to remember that we're treating individual patients, not a group of clinical trial subjects. We look at the results from these trials, and although we are seeing 16%, 20%, 30%, 40%, it's a heterogeneous group of patients that really all act differently. We have to get to a different level of understanding of who these patients are at an individual level, as opposed to just treating them all algorithmically like we have been for the period of time. Some work I did with colleagues of Dr. Sands at Mount Sinai, we looked at all the patients that came through who were clinical trial subjects to try to understand if those patients are really the patients that we're seeing in practice as opposed to the patients that are in trials. And we typically use these clinical trial results to guide our management, to guide our choices, and to let us choose what our next therapeutic changes are going to be. But look at this, only a small proportion of patients that they saw in the office would have even registered into any of the clinical trials that were available at the time for biologics. Almost all of the patients that are being treated in our clinics would never have made it into a clinical trial. So we use these trials and they're helpful. They're helpful to get drugs approved by the FDA so that we can get them into the clinic. But it's only after that that we really understand how to use them and how to use them most effectively. So this is what we all want. We want some combination of genomics, proteomics, the microbiome, the fungome, and everything we can think of that we can learn about patients and take all these little pieces, look in our armamentarium of drugs that we may have available, put it through some sort of magic machine that pops out a pill that's personalized for our patients. That's what we want. We have to understand how an individual patient can be screened using biomarkers, genetics, serologic markers, anything we can come up with to really personalize the pharmacy that we're going to have access to with all the new drugs that we just heard about from Steve and from Bruce. We're not there yet, but we are making progress and we're learning a lot on the way. So I'll talk about the tools that we already have and how we can optimize our therapy with what we're already using. We'll talk about identifying the right patients for the right treatment strategy. Personalized medicine is not just about right drug for the right person, but the right patient at a moment in time with the drugs we have available now and how we can really focus on them. And maybe other patients have less severe disease and aren't quite in the focus of the drugs that we're using or talking about today. And then we'll look towards the future of personalized medicine. So this is what we already have in our toolbox. Steve already said, talking about TPMT heterogeneity, he's going to put us all to sleep. But I will mention and remind us that we're doing personalized medicine with TPMT testing and dose optimization and therapeutic drug monitoring for biologics. We know a lot over now nearly 40 years ago started talking about TPMT Pharmacogenetics and understanding that we can do genetic testing to test our patient and understand proper dosing of thiopurines. We know that most of the patients have normal to high TPMT activity or enzyme level, about 90% of the population. There are 10 or 11% of patients who have intermediate activity, and then this small group of patients who have low or absent activity. We know that we can alter doses based on that. We can use full doses for patients who have normal activity, typically half doses for those with intermediate activity, and we usually don't dose patients who have low or no activity. But again, this is personalized medicine. This is doing genetic testing to help us decide on doses for patients. I tell patients we're doing this. Patients get very excited about the idea that we can do genetic testing to guide our therapy. And then after that, of course, we're able to focus on thiopurine levels and understand how it can dose optimize again in individual patients. We might take a patient and put them on 1.5 milligrams per kilogram of 6-mercaptopurine, but quickly we want to look at their thiopurine levels, understand how they're personally metabolizing the drug despite what their TPMT levels would predict for us, look for efficacy based on thiopurine levels, specifically 6-TG, and we know now for years that higher 6-TG levels are associated with higher efficacy of these drugs. We shouldn't be dosing these drugs at an individual dose, giving it to a patient and hoping that they work. We really can be personalized and individualized in the way that we use these. We're doing this for anti-TNFs as well, and I would argue we're not doing this as much. I think we're leaving a lot on the table without personalizing our care with anti-TNF therapy. The reason we need to individually monitor patients is we need to get it right the first time. Our second or third anti-TNF never works as well as the first one. And the earlier we are, the more successful we're going to be with our patients by preventing disease complications and not letting them get sicker. So what are we looking for with personalizing treatment with anti-TNFs? We're looking for patients who don't have enough drug and we need to give more. How about those who've developed antibodies or will predict they might develop antibodies again in the future and we might use 2 drugs as opposed to 1 drug? Or is this simply the wrong class for the patient? Again, the idea of picking a dose, giving it to a patient, hoping it's going to work is over. We're far beyond that now and we're much more sophisticated in that we can do it. So does this really matter? Do we have enough information to tell us that personalizing treatment with anti-TNFs and proactively monitoring patients will help us? Well, we have pretty convincing data that higher drug levels and lack of antibodies are associated with better remission rates and mucosal healing. We've seen a lot of data now, nearly for 10 years, to help us understand that. And it's not just TNFs, it's across all biologics where we're looking at drug concentrations, looking at antibody levels, and understanding how we can optimize care. We're not quite convinced yet that prospective data has shown us that we can make routine, proactive changes using therapeutic drug monitoring, but boy, it sure does make sense, and the data are accumulating that we're doing better if we think about how our patients could get into trouble and intervene before that as opposed to waiting until they lose response and check their drug levels only to find out what we already know, is they have no drug, high antibody, it's time to move on. If we can intervene sooner, we're going to do better. Here's a very recent publication from Adam Chaffetz's group at Beth Israel, who's really been on the forefront of pushing us to think about proactive drug monitoring. In this multi-center retrospective observational study, they looked at consecutive patients with IBD who responded to infliximab induction therapy and then subsequently received maintenance infliximab using either proactive, meaning checking levels before you have trouble, looking at a specific time period and then adjusting your dose, versus reactive testing. Reactive testing is patient got sick, let's check drug levels. Patient had a drug reaction, let's check drug levels. And you could see here in this observational study, again, not a randomized controlled trial, but in an observational study, there were fewer infusion reactions, fewer hospitalizations, and significantly fewer surgeries if you're proactive and individualized therapy as opposed to waiting for your patients to fail. Again, it's not just anti-TNFs. We see this across biologics, and we see pretty convincing dose-response curves with Vedolizumab if you look at their remission rates and higher trough concentrations. We now have the ability to look at Vedolizumab trough levels. We'll soon have the ability for ustekinumab trough levels. We don't know exactly the goals that we're looking for. Just as it took us a little while to understand this with anti-TNFs, we'll figure this out with these drugs as well. But again, this fixed dosing that we've used in clinical trials was fine for the clinical trials to get them approved by the FDA, but not fine for optimizing the care and individualizing care for patients as we use them in practice. One tool that you can use if you're interested in this idea of proactive drug monitoring or reactive drug monitoring is a tool that I developed with colleagues of mine as part of the Bridge group called the Anti-TNF Optimizer. If you get drug results back and you're proactively or reactively checking drug concentrations and antibodies and you're not exactly sure what to do with it and you need a little bit of guidance on how an expert panel might have taken this individual patient, with this optimizer you can put in the specific patient scenario, the drug concentration that you got back and the antibody level, and it will give you guidance on what your next move can be. Again, an individualized move, not a paradigm where there are 4 different choices of either increasing drug, increasing dose, decreasing dose, spreading out interval, or switching to a new drug, but multiple different scenarios where you can think about that individual patient. This is work that's really cool and evolving. This is done by one of Dr. Santa's colleagues, Dr. Marvel Dubinsky, and Diane Mould, who's an expert in PK and pharmacokinetics of anti-TNFs. We're typically stuck in this habit with infliximab in particular of using either 5 milligrams per kilogram or 10 milligrams per kilogram and giving either 8 weeks or every 6 weeks. And we don't have a lot of other moves that we think about. It's sort of one or the other. Let's either double the dose, decrease the interval, and see how we do. But what they're doing is this work on dashboards, which use covariates that influence the pharmacokinetics of the drug to develop a more precise treatment recommendation based on individual trough and antibody concentrations. What's interesting, when they put it through this mechanism, they found that there were only 14% of patients, of all the patients treated with infliximab, that were actually optimally dosed. about 90% of patients needed some dose adjustment to make sure that we got the right dose for that patient. So again, not only can we check drug trough concentrations and antibodies, but we can think of individualizing dose based on predictive pharmacokinetics in a patient based on different variables that go into this model. Something, again, that's not quite ready for prime time, but coming soon. And I think this is really going to change the way that we use biologics over time. Let's talk a little bit about this idea of selecting the right patients for the right treatment strategy. I think a fundamental problem that we have in IBD management is that we wait for patients to become sick enough to use our best drugs. We watch patients over time fail steroids, we watch them fail immune modulators, and then finally we give them drugs that we wish we could have used a couple of years before that, before they developed complications and before they got into trouble. There are a lot of barriers of why that is. Part of it's on us, part of it is we don't feel that the patients have, quote, earned these drugs yet, and we know there's a lot of resistance from patients as well when they might be early on in the course of their disease and they don't feel quite ready for these stronger drugs, or they're fearful of adverse events from the drugs and not fearful enough of adverse events related to their disease. And I think we focus too much on disease activity, which are the symptoms, as opposed to their overall disease severity. When they're in the office and they're talking to you about their symptoms, that's activity. That's not really disease severity, and we have to sort out those two concepts, and I'll bring that up in a moment as well. So if we can determine disease severity for an individual patient, that is some prediction over time of are they going to get into trouble, even if they feel okay right now, then we can really start thinking about our treatment strategies better. If we wait for our patients to get sicker and sicker until they feel like they need the drugs and until we feel justified to use the drugs, the vast majority of the time it's too late. They've already developed irreversible consequences of their disease that will only be fixed by surgery, and not any of the great medications that you've heard about are currently being developed. There are patients where step-up therapy is probably fine. There are probably patients who don't need any medications at all if we just watch them closely. But there are definitely a group of patients where we have to be aggressive early on in the course of their disease and make sure we treat them appropriately before it's too late. And again, distinguishing this idea of activity versus severity. Please think about this when you're seeing your patient in the clinic. Activity is reflecting really their cross-sectional assessment of biologic inflammatory impact at a moment in time, where disease severity is everything that they've experienced from their disease or might experience from their disease over time. Really what this is how is your patient today, which is important to make them feel better at the moment, but doesn't have as much impact on thinking about a therapeutic strategy overall as opposed to their disease severity. What's your patient's course been over their history of their disease? And also, what might you predict will happen to them in the future based on what you know about them at this time? So this idea of choosing the right Crohn's disease treatment strategy is tricky. It's tricky because not every patient needs top-down or early intensive therapy. We don't want to undertreat patients, but we also don't want to overtreat patients. We want to determine who's at high risk versus low risk of disease complications, and we want to personalize our treatment plan. We want to put this all together in some way to really make these personalized treatment strategies or personalized treatment recommendations, not just what drug do you need today, let's try it and then move on to something else if that doesn't work later. There are a number of ways and a lot of people working on this, and I think this is a critically important point of risk stratification. I'll show you the work that we're doing at Dartmouth with some other colleagues, just to give you an idea of where I hope the field's going, whether it's our work that'll get us there or others. I think this idea of risk stratification, again, is critically important. This is a mathematical model we built a couple of years ago that helps to risk stratify patients based on a mild, medium, or high risk of developing complications of the disease. Complications defined by strictures, internal penetrating disease, or needing surgery. Can we identify these patients before those things happen? And if we think somebody's at high risk, we're going to feel a lot better about being more aggressive about their care early, as opposed to the patient who is a low risk of disease complications. In this model that looked at about 700 patients with Crohn's disease to figure out what the variables were that were important, it was a mix of clinical variables. Here it was small bowel disease, left colonic disease, and perianal disease. There were some serologic markers including ASCA, CBER, and ANCA, and the genetic marker NOD2. When you put this all into the model, it has a pretty good predictive value. The Harrell C, which is a concordance index or C statistic, is really your predictive value. 0.5 is no better than chance, 1.0 is perfect. Anything over 0.65 or 0.7 is considered pretty good for these types of complex models. And here you can see that when we built the model, it came to be at 0.73. But when you build it in a group of patients, that really doesn't help you know if it's going to work in others. So we looked at 2 different cohorts of patients, completely different groups of patients, and the model behaved exactly the same. So we're building confidence that predictive models can work and can get better over time. Well, we used to do this because these mathematical models don't help us too much if you're sitting with a patient and telling them that their hazard ratio is 7.23 based on their log of their ASCA result, and that's never going to help you get a patient on the right drug at the right time. So we use this technique called system dynamics analysis to try to communicate this patient so we can really engage the patients in the decision as well. System dynamics analysis is a methodology that addresses the inherent dynamic complexity and interaction between variables. It's not that different from multivariate logistic regression, what you've probably been seen presented multiple times at DDW over the past few days. But the advantage here is that it provides a real-time, individualized prediction of outcomes. It has a very simple input control panel and then graphically conveys the output over time, and also gives us the ability to add new data to existing models as we learn more from all the work that's being done. Really what it is it takes a complex clinical data scenario and tries to make it a patient and I would argue provider-friendly result. Let me just show you a couple of examples of how this model works and to think about how you might personalize your thinking when a patient comes in. We're using this as part of a clinical trial now. Patients come into the office, we talk to them about their therapy, they have blood drawn that gets sent off to the lab, it comes back in a couple of days, we put it into the model, and then send them this as an email link to patients. Patients will click on the link and they bring up their personalized model. It has their name on it, it reminds them of their diagnosis, and talks about the specific complications that we're looking at. In these cases, again, the time to developing a stricture, internal penetrating disease, or having a surgery. And what this graph shows you is from the moment of time today, over the next 3 years, what this patient's chance is of having a complication from Crohn's disease. Here, this patient has a high risk of developing a complication over a 3-year period. We don't use this tool to convince patients to go on therapy. We use this tool to risk stratify patients. This is a different patient who we saw in the clinic who has a very different chance. Although this patient might come in with the same symptoms, the way that we treat them and the strategy we develop for them should be very different in this patient versus the patient that we saw before. This is just to show you that the model's behaving as it should. We presented this work a couple of days ago here at DDW, showing that in fact over the first year and our first 120 plus patients that we've seen come through, the low and moderate risk patients have had lower chance of complications, where the high risk group have had double the amount of complications that we saw in the lower risk group. Again, if we can identify high risk patients, let's treat them differently than patients at lower risk for their disease. Now let's talk about the future and some of the really cool stuff that's coming. There's progress on this, and we're getting a lot closer by looking at clinical markers, genetic markers, and also cytokine markers. Clinical markers aren't that surprising. We know that some patients are going to respond to these drugs differently, but what can we learn? In this work that's been done by Parambir Dulai and the Victory Consortium working with Takeda, there's some predictors they found, including no prior Crohn's disease-related hospitalizations, no prior TNF antagonist exposure, no prior fistulizing disease, and baseline CRP concentration can stratify the chance of responding to vedolizumab in different scenarios. They've developed a scoring system so that you can put your patients through this system and again, give your patient an individualized prediction of their chance of responding to vedolizumab. Something that needs further development, but I think really interesting. Now look at this. This is a drug that we heard about a little bit earlier. This is etrolizumab. This is one of these anti-beta-7 antibodies. And it was recognized that patients with colonic tissue, so biopsy specimens from these patients that had high levels of the alpha E gene, ITGAE, had better responses than those patients who didn't. And the differences in this ITGAE and something called the granzyme A mRNA levels can identify patients with UC who are most likely to respond to etrolizumab. Look at the delta here. Look at the difference in this group of patients who had high expression of granzyme A compared to those who don't. Imagine that a patient comes in for their colonoscopy, you take biopsies, and those biopsy results can help guide you and give you a specific chance of what that patient's response would be to a specific medication. Whether it's etrolizumab or others, we're learning a lot from this idea, and I think we have a lot more to learn in the future. Here's another drug that came up earlier, brazikumab. This is looking at high levels of interleukin-22 associated with a higher response. I'll remind you, this is one of the anti-IL-23 cytokines, but IL-22 is a cytokine whose expression is induced by IL-23. And this is a publication that just is in press now, Bruce, correct? It didn't come in your journal quite yet, but coming soon. And what Bruce and his team showed, that the patients who had the highest levels of interleukin-22 had a significantly higher response rate than others. Again, think about patients coming in, you take biopsy of their colonic tissue, you get serum, and you look at interleukin or cytokine levels to help us predict which drug is most likely to work in that specific patient. So in summary, we already have tools in our toolbox to individualize therapy. Don't forget about them, use them, optimize these drugs that we have now. We need to select a treatment strategy that looks at future disease risk, not just the cross-section of how your patient's doing today, but think about what your patient's future may look like with that disease, whether it's clinical markers, whether it's the predictive tool that we're developing or others. We have to try to look into the future and be more aggressive in those patients we're worried about. New techniques are evolving quickly to select individual drugs for individual patients, and I hope I've convinced you that the era of personalized medicine for IBD is bright.